direct patient care, research, teaching, management, supervision, and patient advocacy in outpatient, long-term care, mental health, and hospital settings. Dr. Tennison has experience in numerous quality improvement endeavors and has participated as a QI committee member and facilitated same as chairperson and organizational director. For specific areas of focus encompass patient-centered care, patient satisfaction, and health behavior change, as well as leadership and healthcare administration. Dr. Tennison currently serves as project coordinator on the Beacon Project.
Holy moly.
Did it!
That's a lot. I think I wrote that, and I'm like, oh, kind of embarrassed I put all that in there. So give me your impressions so far of healthcare. Are you surprised to know that, the doctors have some barriers and things like that? Have you ever noticed that when you go see your provider?
No.
No?
Well, no, I mean, it's pretty obvious that there's a lot of gaps too.
What's that?
Yeah, it's pretty obvious.
Pretty obvious what?
That there's gaps.
Gaps.
And a lot of opportunity for quality.
Okay, okay.
I was surprised because I never worked in the healthcare industry before, and I was really surprised that doctors keep track of that. I had no idea they cared whether they were doing a good job or their data in their numbers. That was totally new for me.
Okay. Well, and
Person.
it's thank you. So, and I've worked in healthcare for a really long time, and the independent clinics, and I worked for Intermountain for 10 years, they have quality improvement departments and executives and these little, I call them the mom and pop shops, the clinics that maybe have one or two providers and have a huge population and have a medical assistant that's a high school graduate and an office manager that's a high school graduate. And measurement is actually kind of foreign to a lot of these folks. They're just practicing medicine. I'm schedule the appointment, I see the patient, and they go home and do whatever they do. So this is all so new to a lot of people. A lot of people it's not. But as Sarah was speaking, I was thinking about a report that I read on why physicians don't have better blood pressure control with their patients. And they went out and they, these people went out and did this big study, and I think they asked like 5,400 primary care doctors across the United States, why do you have such a hard time with blood pressure? And they had 54 reasons that they came up with why they didn't have good blood pressure control. And so it's really interesting. And then they further categorized it into provider issues, patient issues. And, I was wondering, as you're sitting here thinking, well, why is this all so hard? You treat, the patient comes in, they tell you what's wrong, you give them the medication, and you send them on their way. Well, physicians a lot of times don't want to put people on blood pressure medications, and they'll say, you know what, Mr. Smith has been losing weight, he's lost 50 pounds, why should I start him on medication now? He's on the right track. So medicine is all about evidence-based medicine, but it's also it's funny because people think medicine is such an exact science. And a doctor told me that one time, medicine is not an exact science. There are a lot of variables that can affect outcomes. So I have had the distinct pleasure of going out into the clinics and providing actual coaching services. And I have learned so much from that experience. And I've worked in outpatient and inpatient care, and so I've had my personal opinions and views of healthcare. Probably, it's good, but not great. And going out and doing, meaningful use with the providers, and talking to them about having their patients under better control and having this data. And I'm like, well, why are your numbers so low? And they'll say, well, I don't know. The patients won't do what I tell them to do. And I said, well, why not? Right? Why not? And they're like, well, I don't know. I'm just here to treat them. I don't, how can I be held responsible for those high numbers? Not my fault. It's the patient's fault. Okay? And not all providers say that, of course. The honest ones will say, yeah, some of the patients have a lot of issues, like Dr. Masidas talked about. you know, we don't leave our personalities at home when we go see the doctor or go in the hospital. And so, you know, I have an MSW, that's Master's in Social Work, so I'm a real feisty kind of patient advocate. And it used to just drive me insane when I'd hear the doctor say that patient is non-compliant, because it makes the patient sound like they're really bad and they're, you know, you're bad, go sit in the corner. For some reason, that patient isn't doing what I tell him or her to do, and that means there's something wrong with them. It couldn't possibly be the provider, right? When I was over at an Intermountain outpatient clinic, and this one doctor used to walk in and she'd slam the door and lean up against it and start cussing. And she would tell me, oh my God, this patient's in here. I don't know what to do with this person. They're all over the place. And I'd say, bring them in, okay? Bring them in and let me talk to him or her, and let's figure out what's going on with the patient, okay? Because a lot of times the providers in their 15-minute appointment, they don't have time to figure out what's going on in that patient's life, okay? Because we live our life, 99 hours, you know, away from the doctor's office. So anyway, so 4th Street Clinic is one of my favorite clinics that I was assigned to, and they became involved in the Beacon project, and they were doing really well, kind of to begin with, and so we decided to put them, we call them the Robust Clinic. That's kind of that advanced clinic. So how many of you know anything about the 4th Street Clinic besides Sarah? Okay, so it's a part of the Wasatch Homeless Healthcare Incorporated. It's a nonprofit agency that was started by one physician who had a vision of providing health care to homeless folks, okay? We have a lot of homeless folks here in Utah. So thinking about health care for homeless patients, think about how difficult it is for us, you know, that have a home to be adherent to medications and treatment plans. Well, think about what it's like when you're homeless. Okay, helping the homeless. So these are people, being homeless means you don't have a place to live. You can also, you're also considered homeless if you're shacking up, sleeping on somebody's couch, like a friend. That's considered homelessness. So they see a lot of homeless patients every year. And the reason I love these guys is they treat every single homeless patient just like they would you or I. They treat them with the utmost amount of dignity and respect, and that's why they're so successful. So their mission is to increase the homeless Utahns' access to primary care. They're a major partner in ending homelessness. They also help patients get housing, and they do a lot of care management, helping patients get on Medicaid and get some services that they don't have. They have a lot of children and families. They work with the shelter to provide emergency shelter and food. And ultimately, they're saving Utah some money by providing such good care to these folks. Okay, so they were founded in 1988 as a triage clinic, meaning they were just sort of a clinic where you come in and we'll tell you what's wrong with you, and then we're going to, they partner with all these different healthcare facilities and would kind of send them off somewhere else to get treated. So today, they're a staff of 50. They're located on 4th and 4th, downtown, right across from, was that Liberty Park? It's a beautiful clinic inside. It's very comprehensive. As you can see here, they treat a lot of people. They have more volunteer providers than they do actual staff, and we'll talk about that a little bit. It's been kind of a problem for them with their EHR, having 150 different people coming in trying to use the EHR that have no idea about anything about to do with EHRs. But so they have their own pharmacy. Everything they do is in-house because you can't send a homeless patient off somewhere else for treatment because they don't have cars a lot of the time. So lack of transportation is a big issue. No housing, no insurance. Most of them are uninsured, although some of them do have Medicaid. They have poor health literacy. You heard me ask Dr. Masidas about that a little bit earlier. What does that mean? that means we could talk to you about your health care, and we're talking in such big Latin medical terms that we're going way above your head. A lot of them don't have formal education. They lack trust. A lot of these people have comorbid behavioral health problems. A lot of people with schizophrenia, a lot of substance abuse problems, and they just don't have the capacity to take care of themselves. They have a pretty high rate of hospitalization, especially in the winter time, because they're out sleeping outside and have high rates of pneumonia. They don't have any place to put glucose if they're on insulin. They can't have medical equipment. They sleep in the shelter. Well, I had a patient at the shelter one time tell me that he had his medications in a bag and he slept with that bag on his chest because the shelter is nothing but beds and people steal. And so it's not an easy life being homeless, okay? They can't eat well. They eat whenever they can. You see them out trying to get money for alcohol or food, okay? So survival is their top priority, not health. Okay, they're just trying to get through the day. So the 4th Street approach, our homeless patients need more than a Band-Aid. They need these ongoing services, and they want them to have high-quality services just like anybody else to promote better health. And Dr. Gallup is their clinic medical director. She was, or is, the Beacon Clinic team leader. She is amazing. I love her to pieces. She just loves those patients, and we went to her with the Beacon robust plans and said, do you want to be a part of this? It's kind of hard. You're going to have to move all these, these diabetes quality measures. And they're like, no. She was like, no problem. And so I was like, wow, cool. She's on it. And they have a great team there. And I respect these people probably more than anybody. This is Fong. He's a pharmacist, but he's also a diabetic educator. And this was actually in the Deseret News maybe 2 weeks ago. And the young man there, I can't remember what his name was, but he has diabetes. And he was talking to Fong, and Fong is trying to use just regular things that he would recognize. And he actually draws on their hand to show them what a serving size is, which I thought was kind of cool. And I remember the young man there saying, yeah, I eat once a day maybe if I'm lucky, and so I'm not really worried about the nutritional content. I'm probably eating way too many carbohydrates, etc. So as you can assume here or see, these people have a lot of things going against them in taking care of themselves. So as part of being in the Beacon Project, here's one of our graphs again. This was the A1C control. You could see where they started over here. Oh, I have a pointer thing. Down there, and they went up and surpassed their goal. And they did it fairly rapidly. And all of I didn't want to put all their measures up there, but they did a really pretty rapid increase and met all their goals. They were one of the first clinics to do this. And the way they did that was just sheer tenacity. They're like, we are determined, we are going to do this. And they got everybody involved. Cholesterol screening rates started pretty low again and zoomed up high and stayed high. And we kind of brag on these guys because we're like, these are folks that are taking care of homeless patients who are probably some of the most difficult patients in the state. And look what they're doing. So we kind of shame other people. Like, if they could do it, why can't you do it, right? Okay, so what makes Beacon work for them? Sarah talked a lot about the provider, the clinic champion. They have, of course, a board as their governance model, and it's people from Intermountain and things like that. And so they have proven to that governance model that they kept dashboards, they kept a lot of their data they would show to them every month at their meetings. They had dedicated resources to data management. That was really, really important. As Sarah kind of talked about, and I think I spoke with George, you know, we were shocked to find out initially that the EHRs weren't weren't able to have us extract data from them, and so we've had an analyst that goes down there like every week to pull their data for them and do their graphs, and so they actually had hired a gal to do that for them, and they survive on grants too, so they're looking for money right now to continue to keep her going. The incentives to the provider team. Now, Sarah talked about this a little bit. You know, I work with another clinic that they did not want their docs to know that there was a monetary incentive for them because they didn't want people to do it for the money. They wanted to do it for the quality. And 4th Street said, no, we're gonna tell them about the money and we're gonna dangle that big carrot right in front of their noses. And they put report cards all over the place. They have them on bulletin boards. Everywhere you go, you see who is who's in the lead with getting their measures up. And so, to me, that's worked very well. They were the first clinic there. So, feedback loop for performance. Again, I'll show you these report cards in just a minute. But as Sarah said, docs can be very competitive. 4th Street Clinic works in they're called teamlet models. So it's a doctor and a medical assistant. That's the person that usually takes your vital signs. And they would kind of grade that teamlet model every month. And they would say, hey, this team's winning. And they would post it all over the place. And as we have looked at what has worked in Beacon, you know, we're stepping back now and saying, wow, we're almost at the end. What has worked? Report cards, interestingly, have worked very well, and that looks to be sort of a national situation as well. So back to that transparency with the stakeholders, you know, having the dashboard, and the dashboard is displayed everywhere. So these folks are extremely transparent. We've tried to use the report cards in a couple of other Beacon clinics, and some of the folks are afraid to show their data because they're afraid the providers will get mad and upset. So I could say for these folks it's worked really well. HealthInsight staff guidance and support. Like I said, I go down there probably, lately it hasn't been as much. In the beginning we went down there to the clinics probably every week, and then as they kind of got used to quality improvement and we got them kind of launched, they did really well on their own. And since they already got their incentive check, they're kind of moving on to the next thing, which is their patient-centered medical home initiative. And bless you, our REC folks that you probably heard talk yesterday still go in and help these guys a lot. They have an EHR that was bought out by another company, and every time these folks have an upgrade with their EHR, something magical happens to their data. And it gets a little skewed sometimes, and so they have, you know, these updates, and they're frightened of what their denominator will look like the next day, and actually that happened to them. Like, oh gosh, so we kind of had to change our measurement a little bit to accommodate them. Okay, let's see. This is really hard to see, but this is the team comparison, and this is what they use. So you see the first names here, and who's doing the best. So that, you know, these folks up there, 95%, and that monetary incentive that they got. They said that the team that gets us there the most, who has the consistent highest scores, will get extra bonus. Here's another one of just showing the clinic average. See, this is their goal that we set them up with, the clinic average. And then if you can see over here on the right, it says my team is 96%. So they went way over, well, not way over, but they went higher than the clinic average. And I imagine they got some money that they're outspending right now. Okay. Training the large number of volunteer providers was really hard for these guys. And when we first started pulling data, They were putting it everywhere. You can only pull out what's been put in a certain specific place. So, they were putting foot exams probably in 10 different places. They were putting eye exams in different places. And so when we would extract the data, we couldn't find it because a lot of times it was in free text. And so we had no idea what they were actually doing. And they're like, we know we're doing this. And the problem was their volunteer providers typically come in once a month. These are the doctors and nurses and things, specialist doctors, come in, they see the patients, and they leave. So they don't even sometimes even see the providers. And, okay, now we got to pull them back and try to train them all to document consistently in the medical records. And as Sarah spoke about a little bit earlier, that was a challenge for us in a lot of the clinics, was getting them to just be consistent. The program updates that changed the denominators, continued funding for that data management person. Again, they're trying to find a grant to continue paying this person's salary when we're all finished. Consenting homeless patients to the CHI has been a pretty difficult activity for them, because the homeless patients tend to have, like I said a little bit earlier, a lot of comorbid mental health issues, a lot of schizophrenia and bipolar, and a lot of substance abuse issues, and they don't want to sign anything that sounds like Big Brother is going to be involved in their care. And I say Big Brother, we went out and did some focus group studies of folks about the CHI, and that was the term we kept hearing a lot. I don't want Big Brother in my records. And so they have a tendency to be a little paranoid, and this made them a little bit more paranoid. So they're actually having the FONG, the health educator, doing that for them, so he can sit down, take the time, and explain to them what it's really about. If you can imagine, having those folks' information in the CHI is very important, because they're transient a lot of times and get seen at a lot of different healthcare facilities. And so having one place where we can pull it from is really important. Okay, so again, they were one of the first clinics to reach their robust goals. They have learned the importance to use data. As I said when I got started, a lot of folks, this is so new to them, the concept of data and having to prove what I'm actually doing. Nobody's really cared about that before, right? I just submit my bill and I get paid. Well, now having that data to actually see what the outcome is has been a real eye-opener for a lot of people. They've really improved their patient flow processes, meaning, the patient comes up to the front desk, gets checked in, and a lot of times they do different things that really slow that flow down. They want to make sure that their care is as efficient as possible. They have same-day appointments. Patients walk in, every single patient that walks in gets seen that day, and they get a full spectrum of care. They don't send them out for anything. They have an optometrist there. They just got a big grant. They're building a huge dental clinic back there, so they're really going all out. So, improved understanding of quality improvement processes, and they are now working on a medical home designation, and I'm sure they will get there fairly easily because they do such a great job. So that, I'm not ready for questions yet. That was one of the clinics that I work with, just to kind of give you an idea of the actual on-the-ground processes that happen there. Okay, I got 5 minutes left. I wanted to go back and talk about the clinic that Sarah showed you, that we're doing the care coordination program. This is something that she and I put our heads together, and I'm very adamant about, as you probably could tell back in the beginning, we can't just keep telling patients what to do, and then when they don't do it, call them non-compliant. We need to take the time to figure out why they're non-compliant and what's going on with their life. Problem is, don't have that time to do that, and so I started reading a lot of literature and seeing that the medical assistants actually could probably take some of the non-provider work away from the provider and do some of that and alleviate some of the provider's work. And a part of medical home designation, it's called team-based care, trying to turn the provider from being the conductor of the orchestra to being more of a member in the orchestra, still having a leading role, but maybe not being as much in charge. And so we had this hypothesis that the medical assistants could do a really good job of figuring out what's happening with the patients. Well, and we know that medical assistants will, patients will tell medical assistants things that they won't tell the provider, okay? This patients lie to you all the time, right? You ask them what they're doing, they'll say no. And I've talked to patients a lot and asked them, well, why do you do that? And they're like, I don't want them to think I'm bad. And so they won't often be honest with their provider. So we figured the medical assistant is probably less of an authoritative figure, and so maybe they would be more willing to talk to the medical assistant about what's really going on in their lives, okay? Health literacy, 40 to 80% of what patients remember, any patient, they will forget 40 to 80% of what they learned before they walk out of the door, okay? If you have health literacy problems where you don't really understand medical terminology, and you can be a rocket science and still not understand that, they're going to walk out and not understand what they're supposed to do. It's very prevalent. It's a lot more prevalent than we knew, and it's interesting to me that health literacy is becoming sort of the new thing. My gosh, why did it take us so long to figure that out, right? Because we talk to you like you're us, and you talk to your buddies about technical stuff, project management stuff, that I'd be like, I don't know what you're talking about, right? So we taught the medical assistants motivational interviewing, like Sarah said, trying to pull out what is going on with the patient, what is wrong at home, what's happening with you that you're not able to undertake the treatment that you need to. And so finding where patients are they even ready to change a health behavior? We forever have thought because we tell you need to quit smoking that you're going to quit. Well, guess what? Does that work? They're not ready, okay? How many of you have tried to undertake a exercise and you did it really well for about 6 months, and then you hurt yourself or something and you kind of spiraled back to not exercising? So we taught those medical assistants how to do that with the patients, find out what's happening, and then work with them from where they are, and then try to help them get to where the physician wants to be. So that's something that we just personally believe works very well. We have the data now to show that those patients that had that kind of individualized, specialized care did very well in their diabetes care. They all had dramatic improvements in their health care, and that isn't, talking about healthcare reform, patient-centered medical home, which is what we aspire to be. Care coordination is a very big part of that now, and so I am jumping up and down with joy to know that we're going to be able to take the time to really figure out what's happening with folks. So my time is up, and I have 15 minutes for questions, and can keep going if you'd like. Yes, sir.
The patient-centered home care is basically calls to the home, to the patient and talk to them about their disease, right? And what they could go and do for it.
So I'm not understanding.
Because
The patient-centered medical home?
Thinks it's an
Yeah.
in-home.
Oh, okay. It's funny because that's a lot of people think because it's patient-centered medical home. It's actually primary care. It's still in the clinic. It's called something different, primary patient-centered, meaning that instead of the doctor, again, telling the patient what to do over and over and over, we're going to bring the patients in and we're going to put the focus on what your goals are. Okay, I need to let you know what my goals are as a provider, but I also want to have a shared care plan with you. What's going on with you? Okay, instead of me just telling you what to do, not knowing your home situation, I did an internship at the VA hospital in St. Louis, inner city, and all of the patients there were African American men, and all of the providers, say 99% of the providers were white. And in East St. Louis, it's kind of the neighborly thing to do to sit out on your stoop every Friday night and have a Schlitz malt liquor, okay? Have 1 or 2 or 3 or 4. And so a lot of those patients were on dialysis because they had untreated hypertension. And so I would go into the dialysis center and they'd all just be in there griping about the providers. You know, they just don't understand us. You know, what's wrong with them? And I went to the dietitian and I said, you know, is there any way in the world you could let that person drink 1 beer and put that in their diet somehow? Because they're going to do it whether you do it or not. So why can't we figure out their lifestyle and try to make their treatment work with them instead of against them? So that's one aspect of patient-centered care. One of the some of the other components are having better access to your provider, meaning you can, instead of going to urgent care or going to the emergency room, you know, you can call your provider and somebody will call you back. It's getting into the doctor the same day or the very next day. It's having improved communication with your provider, having the things like we've talked about, patient portals. So it's kind of it's funny because a lot of people say, I've been providing patient-centered medical care, you know, forever. How is this different? It's a different philosophy, basically, and it will require that providers get paid differently because the visits hopefully will be longer and more team-based, so you'll be talking to more people than just the provider. You might have the medical assistant calling you at home and saying, hey, how's that medication working out? Are you having any side effects? So it's a lot more hands-on, patient-focused. Good question.
Jen, another piece I think that's important, though, is that there are conditions that don't need a doctor. Like
Yeah.
the nutritionist does a better job, or the physical therapist does a better job coaching on education for activity. So it actually, and a pharmacist is much better at helping you make sure you're taking your drugs right. So it's also like, you know, who is the right care provider? Or there are conditions where, why do we have to see patients for this? If we have good protocols and communication with our patients, you know, we don't even have to see them, and yet we can monitor them. So it kind of loosens up the kind of care that's provided.
Yeah, it's not, I don't want to, you know, I think sometimes, I have good relationships with my providers where I could call and say, hey, you know, can you prescribe this for me? And I don't even have to go in. But most doctors won't do that. You know, you have to, oh, you need a refill, you need to come in, make that appointment, take time off from work. This is trying to make healthcare more accessible. It's available at times for people that work. Just trying to make it so it actually meets your needs, it's not for us, it's for you. Isn't that awesome?
I've seen a lot of improvement when it comes down to, you know, like going to the, not necessarily a specialist, but going to a nurse that knows about the diabetes and sit down and talk with them. That's just,
Yeah.
I've seen that sort of thing.
Yeah.
It's been very effective. But my wife also occasionally gets telephone calls from somebody, you know, regarding her diabetes.
Mm-hmm.
And they'll be on the phone for an hour and a half.
Yeah. Yep. That's care coordination and care management. That's exactly what that's for. I know you told me you go to Intermountain Taylorsville Clinic. Yeah. Intermountain has, they are in the process of making all of their clinics, they call it personalized primary care. It's actually patient-centered care. It just has a different name. But going to that type of a model where it's not just you coming in front of me. It's us following up with you to make sure you're not having problems with your, you know, side effects with your medications and things like that, because you might only come to see me once a year. And so I need to make sure that when you leave, you have the tools that you need to self-manage. And that's what we're trying to do, is help patients become more autonomous and have more self-efficacy in taking responsibility for their care. studies show us that, and I say we, I'm a provider, we tell you what to do, but I don't know if you have any confidence that you can even use that glucometer. But that's one of the most important things, is having the education, but also having the confidence that you can even do this stuff. And asking somebody if you have the confidence to take care of this is pretty different. We've never done that before. And so we're figuring that out now, that that's what we really need to do. So, hopefully you will see healthcare just really kind of taking a pretty major shift back to being centered on yourself.
This question may seem a little off topic slightly, but we're talking about this patient-centered home and extra care. How does that translate to, if it does translate to, psychological care?
Oh, okay, good question.
Because especially with the 4th Street Clinic, I imagine
Yeah.
you have that issue.
Yeah. Oh, yeah. And it's interesting because Sarah and I are actually working on a grant right now to kind of do a little study with that. Now, I used to work for Intermountain, and I was in an outpatient clinic, and I helped develop a care process, management process for depression. Okay, and we know typically what would happen. I feel depressed. Here's some Prozac. Come back and see me in 6 months. Okay. And the patient comes back in a year and they're more depressed because they didn't start their medication, they had bad side effects, and so they would leave and get out of our, kind of fall through the cracks. Well, we know that primary care, 70% of antidepressants are prescribed in primary care. They're not prescribed by a psychiatrist. And so we need to do a better job of integrating behavioral health into primary care. I won't say a lot of primary care clinics are doing that. We know that's another logical next step. Some of the patient-centered medical home models do have that in it, where they have the behavioral health component in the clinic. When I was at an outpatient clinic, that was what I did too. And sometimes the docs would just walk somebody right over to me and say, you know what, this person is, I think they have bipolar disorder, can you help them, figure out what to do? And so, like I said, Sarah and I are doing a model with a community health center up in Ogden, where we're going to try to train their providers to integrate that mental health component along in the primary care side. So it's a great question, and it needs to happen.
Well, but I think too, just what we're seeing in idealized models is there is a mental health worker like a Janet on site. Intermountain's done that in a leading way. So you have a resource where that patient is, because again, if they locate a place they go for care, if they can get, whatever stuff they need, they get their prescriptions, they get their physical care need, they get their mental care need in the same place, it makes sense. So there's a lot of federal interest in integrated primary care mental health care. The community health centers, 4th Street and Midtown and Ogden are doing some of that, but it's still, you've got to have that resource there. The other thing our state's interested in is telehealth. Psychiatry resource nurses or physicians that do psychiatry work are scarce. There's not a lot, and so they're looking at doing telehealth as well. And some of our pediatricians have done telehealth consults, even across the valley, where a child needs an intervention and assistance. Could they put them on a screen and do a telehealth intervention with mental health? So I think there's a lot of stuff happening, but mental health patients take a lot of money, especially severely persistently mentally ill.
Yep.
And that's exactly what you're saying. It's got to be somehow located in the same place, probably.
And the outcomes are so much better for those patients that have that continued follow-up. Research shows also that they prefer to have a one-stop shop, right? I don't want to have to go across town and go get, pre-authorization to go over there to see that guy that's, 6 months out. And just because I'm a behavioral person, I don't feel like we have the best mental health services in Utah. I think, when I worked up in the hospital, we would have somebody that needed something, and it would sometimes take 3 months to get them an appointment on the outpatient side. And I'm like, I don't want to send that person home because I don't feel good about it. But so kind of integrating everything into, as much as we can into primary care, while improving that transition, as Sarah talked about, from the hospital to home or the hospital to a facility, making sure we have better connections before we let folks go.
Well, it's harder to measure, isn't it? I mean, with a prescription or a blood glucose level, you can take a test and you can measure it. And so is that maybe some of the reason that it's harder to come online with psychology
No,
stuff?
you can measure it. You measure depression just like you have questionnaires for depression. You have questions for bipolar. You use the symptoms. You diagnose. There is.
It's subjective though, isn't it?
Not really. I would disagree with that, but because I have a book called the DSM-4, now 5, where you look at the symptoms. But it's a lot harder for primary care doctors to treat. Okay, when I was at Intermountain, the reason I was there was to educate the providers on how to treat it, because I noticed one doctor would put every single patient on 20 milligrams of Lexapro, and I said, why do you put everybody on the same dose and the same medication? He said, because that's what I know, right? It works for the patients I have, it works for them. And so I'm like, but this person has a major depressive disorder, and he probably, he has some melancholy features. He probably needs this dosage and that type of medication. And so because it is a specialty, it's like any other specialty, like orthopedics or having the lab there. We know it works to have that in the outpatient clinic, and so there is that movement towards getting that to happen. And I feel like that will also decrease the stigma of mental illness by having it more out in the open versus, go hide over there and go in the back door and see that psychiatrist because your neighbor might see you. It is still highly stigmatized. But thank you for your observations. I love it. Yes.
And this question kind of brought up one here. I've been making an assumption that the mental health clinics and mental health psychologists and psychiatrists, that they are all on this as well. We had a situation where my son is schizophrenic.
Okay.
And his doctor, his psychiatrist, ordered the blood work done to see if his
yeah.
are balanced and that sort of stuff. And when we went to go and get the blood work done, we specifically wrote on there, send this to Dr. So-and-so.
Mm-hmm.
And he never got it.
Mm-hmm.
But his regular doctor did.
Mm-hmm. Part of that, what we've been talking about here too, the care coordination also involves, and here's what's happening. Masidas, let's use him for an example. We need our patient to go see the ophthalmologist. And so we will give them a piece of paper and say, here's his, I'm done. Maybe we could talk afterwards. But, to try to get those connections, those referrals tracked better is also a part of patient-centered medical home because of things like that. So having that mechanism where we can close that loop, knowing who gets the results, hopefully having the CHI would do that.
And then I'll encourage too, give you guys an access to making sure that happens too. Like you have access to those labs, making sure they get to the right place.
Yeah.
We cut our patients off from being able to even help in the
Well, I
process.
have to go get legal guardianship to
Yeah.
do that.
Yeah. And that's a great example of that really important information not getting back to the provider it needed to get back to. So thank you. Hopefully we will do better at that. We're working on it really hard. Meanwhile, you might have to take the bull by the horns and do it for yourself until, we have mechanisms that do it for us. Thank you very much. I appreciate your time.